Okay, let's make a start then. Thanks everyone for joining. This is the Open Data Saves Lives webinar series. Started up during COVID when we actually ran these weekly, just as a means of trying to get data together really quickly. And we've got some really nice use cases on our website of things that started during COVID because we couldn't wait for them to happen at a pace that things normally happen at. It was, if we can get, in one example which is on there, if we can get the NHS numbers and the COVID results from someone yesterday, pass it securely NHS to NHS, as someone arrives in ED tomorrow, we could stream better. And there was just a pace of collecting data that we needed to work with during COVID, which was welcome actually. And with a COPI notice alongside that, we started this off as a kind of a sort of a rag bag of people who got together every week, and it's kind of formalized out of that. And we've got some sponsorship from people like the Health Foundation on today, and TPP, and one of the big commissioning support units. So we've changed the frequency of these, but tried to have them slightly less chaotic and slightly more formal, and pick some big topics. So previously, for example, we did cancer about a month ago, and we had Professor Mike Richards kind of leading that one, and Ellen and I are meeting tomorrow about the sort of program for things that we'll do through next year. One of the big ones we've got planned for October, just as an example, is around inequalities, which is an area I've got a background in studying, I'm particularly interested in, and I'm spending a hell of a lot of time analysing. And we've got much more national guidance around inequalities, and it links directly to some of the things that we're going to talk about today. So one of the things that's really welcome coming out of COVID is there was a lot more attention being applied now to analysing people's access, their patient experience and their outcomes. We've got national directors for some of this stuff, and we're developing some quite interesting statistical techniques to look at it. But because that is very sensitive, it's very helpful to do it in the open, and you can have someone give you advice about this is a sensible analysis, this is not a sensible analysis. So recently if you got asked who got pressure ulcers and split by gender, if it was more men than women, well, you may simply have been treated more men than women, and we need to quickly evolve the analysis into something more sophisticated. So with these big crunchy issues that we need to analyze, our view at Open Data Saves Lives is let's do all this in the open, because if you've got an idea and it's not quite right, you will quickly get someone who will go, that's a great idea, but you need to provide an adjusted metric rather than a crude metric for that, or the ethnicity data over here is really poor, but here's a really good way over here of making it a little bit better. Have you thought about linking these two different data sets together? So thanks a lot for coming. We've got three fantastic speakers, all on that theme of kind of open. I hesitate to say open source, because open source is a sort of term that's been around for quite a long time, but kind of we'll call it open innovation. And three quite different speakers, actually, it's fallen really neatly. So Ellen's going to start off from the Health Foundation, and I think talk about how we get more people working in this space. We've got Chris as one of the few really, really good examples of people working in this space. And we've got Osman to give a kind of GP view, and some of the things that I think we'll get into there might be around some of the IG around this as well. So there's a lot of national communication supposedly coming out of Ming Tang's office this summer. I'm involved down in East Kent in kind of doing patient and public engagement around the use of data. The government have not done that brilliantly in the past. Where most people probably think it's a sensible thing to do, I don't think the communication's been fantastic around it. So those are some of the issues that we kind of want to get into. Over to you, Ellen, and you start, and I'll kind of manage the time and I'll manage the chat. But thanks for joining us, and if you want to share your screen, go for it.
You should be able to see my screen now.
We can.
So thanks for inviting me to coming to speak. My name is Ellen Coughlan. I work for the Health Foundation as a program manager in the data analytics team. So lots of the work that I do is funding interesting projects like Open Data Saves Lives, but often lots of different projects on the ground that helps use data in better ways across health and social care. So I have a background in data as an analyst when I was a job analyst in my last role. I guess I wanted to kind of talk a little bit about open innovation, open data, and the way, I suppose, that I've become radicalized I get my kind of journey with this whole movement has been littered with sort of false starts and obstacles. So I'd like to just tell you a little bit about before I was working for the Health Foundation, what kind of pushed me into becoming this open source acolyte. And my first was a brush with an organisation that was hired to undertake an analysis of general practice, and I was working in general practice as an analyst at the time, so it piqued my interest. And I was already working with my own practices to build a data set and kind of develop analyses for them that would help them to, I guess, to make decisions that would inform their workforce strategies, that would improve the way that they allocate their clinicians and sort of resources that they have, that would help them collaborate on extended hours initiatives and to improve access to their patients, and like loads of really interesting stuff. And so I would say that my team and I and the practices that were really engaged and involved with this kind of analytics initiative, we all had a pretty good understanding of activity. We had a fair understanding of demand. What we did have a really rigorous understanding of was the fact that, I guess above all, there's a really important element of knowing how the kind of idiosyncrasies of data collection really drives how, you know, knowing how people use system really drives how you interpret the data that's come out of that. And so there I am waiting for this analysis to drop. And when it does, it looks quite unfamiliar, I suppose. So I sat down with some of my colleagues and we kind of looked through it, and it just looked a bit peculiar, to be honest. So I decided to kind of take it up with and just kind of inquire with the people who'd done the analysis. And when I say I spent weeks on the phone being passed from person to person, from commissioner to contractor to that organization to you know, software provider, that's not an exaggeration, weeks if not months of trying to chase people up, and nobody could give me any insight into the analytical methodology, their approach to kind of cleaning data, to how they interpreted different fields, and they couldn't tell me who they were kind of consulted from a GP perspective. And this was data that had come from our practices systems, right? So we were kind of being held at arm's length for the sake of like commercial sensitivities, as if they'd have to sort of cut my tongue out if they divulged any of their secrets. And it was just incredibly frustrating. In the end, I did manage to acquire some of their data. I acquire legitimately. I didn't get it off the back of the truck or hack them. I did get it legitimately. But even a sort of cursory validation of that threw up a lot of questions around interpreting essentially what fields mean what, which to me seemed like really fundamental stuff. So I offered them some thoughts and the opportunity to chat with our team, with some GPs that were kind of really fully engaged into what we were doing, and we just never heard anything again. And this is what was wild to me, was that the data had come out of our GP systems, and yet there was this complete sense of unaccountability. So that was experience number one. Experience number two was this kind of long and arduous effort to obtain data. And so I was working with lots of different data sets from different organizations and trying to, like most people, just spending lots of time on lifting and shifting. So we were spending hours pulling reports from electronic health record systems, which meant less of like the fun stuff, doing the actual analysis and trying to think of ways to cut data in different ways or analyze different data in different ways, engaging with patients to find out what they want, engaging with clinicians to find out what they want. And it was taking up so much of our time that we were trying to find different opportunities to get this data, basically. So we got in touch with the software provider, and we were essentially just quoted eye-watering sums of money to access those data sets in kind of a bulk upload, which I assume that that's because they have a proprietary system, like analytics tool, that they would like us to use. And I guess that kind of, it's business, isn't it? It nudges you into using that, and that's good for them. And probably good for other people who maybe don't have the time or the expertise to pull this work together. But as a team, we'd already kind of learned how to use R. We'd been using SQL to kind of wrangle data and stuff, and we loved that. We knew how to do that, so we weren't really attempting at all to use that proprietary software. And that was another experience that just frustrated me, that there seems to be these kind of continual obstacles for people to get the data themselves and just feel like it's a bit more kind of open and you're not needing to use software that you're having to pay for. And then I joined the Health Foundation, and part of my remit is to build capability by funding interesting open source work and really promoting the value of open source tools and approaches. And over the last 3 or 4 years, I've essentially heard those kinds of experiences kind of echoed back at me 100 times. And so I think, yeah, there's just this sense of an uphill struggle to adopt kind of this open way of working for both, you know, for analysts, for data scientists, for anyone else kind of working in this space. So I just want to reflect a little bit on what I've learned from my experience being like at the sort of coalface, and now in my lovely ivory tower where I get to watch and fund other more interesting and intelligent people do all of this work. So I think that analysts and project leads still kind of hold misconceptions about what working in the open means, particularly kind of around licensing that needs to be unpicked a little bit. I've funded dozens of these projects across health and social care, and there's still this sort of cultural reluctance from analysts to share what they're doing. They're not really comfortable with it in many ways. And perhaps some of that is not really wanting to feel exposed and like wanting to hide your workings because it's too messy or it's not quite right, it's not kind of perfect, you haven't done it the right way. But those are obviously all reasons to be learning and sharing with everyone, because you can obviously learn from others, and if you're working more collaboratively, other people can learn from you. But some of that reluctance, I do think, is down to fears around kind of governance and licensing. I often hear things like, I can't use open source tools because they're more vulnerable to information governance issues, or we can't publish our code because if someone uses it and there's a bad outcome, then we'll be liable. So I think that is kind of one challenge around kind of people using data that they're not quite comfortable with it yet. And I think there sort of remain these barriers slightly higher up the decision tree as well. So we obviously quite often hear the familiar refrain of, my IT lead won't let us have this particular program on our computer. And I think that there has been lots of progress from the top over the past 2 or 3 years. And the data strategy commits to kind of removing these barriers completely and publishing things like open source playbooks, which I think are great. But I still think that advocacy from groups like this, people like us all sat here, and sharing stories about how the switch to working more openly has reaped benefits for teams and decision making, I think that's still really important. And I think finally, grassroots organisations have been really essential in applying pressure to senior decision makers like the Transformation Directorate, as well as equipping analysts with the training and tools to further themselves. People like the NHS-R community, they've really hit that sweet spot of kind of pressuring to remove the demand side issues and really addressing some of the supply side issues. So that's incredibly important. So just thinking forward into kind of where we go now, I think we need to all be holding the HSC to account for the data strategies implementation. We need sort of further efforts to make working out more openly accessible, understandable, not really scary to analysts and their managers. So that means more sharing of success stories, more blogs, demystifying some of the topics we've discussed here, more engaging with decision makers to promote the value of open working. I've included here a screen grab of Chris's blog on software licensing that I'm forever sharing with my project leads, and also a blog by Open Data Services, Simon from Open Data Services, about how they created an open source standard that was co-produced with Equal Care Co-op, which is a social care provider up in Halifax, and people living in Halifax that care for people and that receive care. That was a project I funded last year that really tried to rethink how social care contracts should work based on being accountable to the people that are receiving the care and their loved ones. And I guess I keep coming back to this idea of accountability. So I think that there's more that we can do to kind of do this kind of advocacy work. And I think we have such a wealth of experience across, I guess, not just public and industry sectors, but academia as well. But I didn't know how to do like 3 handshaking, so I've just got the 2. So I think in kind of these unprecedented times, we need to make sure that we're using all of that expertise well, but in ways that promotes better learning and sharing and working together. We shouldn't be finding ourselves in situations where methodologies, evaluations are hidden from customers or potential customers, because people procuring, say, data-driven tools from the private sector should be able to do so equipped with really sound understanding of how those tools work. And those with tools already deployed should have a really good understanding of, whether over time that tool is going to remain effective, equitable, and safe for their patients. And this is actually a whole subject in and of itself, to be honest, that requires investment in analytical literacy and capability at the kind of senior decision maker level, or investment in analytical roles, or in senior analytical roles that kind of brings people a bit further up their career trajectory. But I think that the crux of this kind of comes down to everyone being willing to work more openly. And finally, I think we just need to make our communities' futures secure. And I think that means growing memberships of communities like Open Data Saves Lives, like the NHS-R community, diffusing responsibility for things like organising some of these conferences or, training, things like that. And I think that could look like funding from some central organisations to support that. As I'm sure colleagues will tell you, having things like Open Data Saves Lives and NHS-R running so successfully takes a lot of focus and a lot of time and patience. So I think the more people that can share events like this, the better. And I think you'll be watching this because you're already part of, you've already kind of been attending some of these event series, or you're interested in open working. So I would ask each of you, here's some homework, ask each of you to kind of share a success story or a question relating to working more openly, either here in the chat or on Twitter, and tag Open Data Saves Lives, because I want to find out who else is in the community, and I want everyone to be telling their stories about why working like this is the future, and kind of let's demystify some of those concepts. So that's your homework for me, and that's the end of my presentation.
Ellen, that's really helpful as ever. I was being grumpy in the chat about, it's all very good developing analysts, but we need that proper conversation at kind of senior level, which you then started to speak about. So it's brilliant. And I've put in there as well, I wonder if the ICBs coming into place might help make that case even more, actually. It still feels a little bit like it's people like us, Chris, who's just come on, is this sort of fantastic analyst, but I still believe there's a lack of literacy, as you called it, at a kind of a senior level. So Chris does some analysis, someone taking that on, understanding it, not feeling ambushed by Chris, not being scared of some of the language that he might be being unfair, Chris, because I haven't seen you. But you can imagine there's a group of people who I think struggle with some of the, they go into a meeting and it's going to be about evaluation, and they think, oh Christ, I know that, I remember this. There's different ways of doing it. What's a real? He's just said real world evaluation. What does that mean? And there's something about a kind of senior level literacy of people who want to take big roles, who need to come and engage with people at this level to understand those things, so they can do proper. If you're going to centralise stroke services in Kent, well, let's do it properly. Let's do it based on some data, not just do it on a hunch. And I think there's some work to do around that literacy. So I'm really grateful for you kind of beating the drum for that. I've got a minute or so. Any quick questions for Ellen, or please, Ellen, if you keep an eye on the chat, there's sort of questions and things coming in there, and I'll kind of move us on to Chris. Chris, thanks again for joining us. I really appreciate this. We kind of hold you up as a unicorn every now and then, because there's not there aren't unfortunately 200 of you yet. There's only one, so we'll keep going. But over to you, and thanks for joining us again.
Yeah, people do ask me sometimes why my trust lets me do all this stuff, and I'm afraid I don't have a good answer to that question. My trusts are pretty great, actually, but I don't think it's just that. I don't think it's me. I don't know what it is. It might be history, or I don't know.
Said Chris Beesley the day before they threw him out the window.
Yes,
yeah.
I'm very lucky, and I don't forget that. Anyway, right. I get very confused by all this slide stuff. Oh, never mind. Oh, yeah, there it is. Okay, cool. Yes, so hello. So my name's Chris Beeley. I'm a data scientist. I work at Nottinghamshire Healthcare NHS Trust. I'm also the co-chair of the NHS-R Technical Advisory Group. So I'm going to talk about open code today. There was just a question in the chat moments ago about whether we're talking about open code or open data. It's an important distinction. I will only be talking about open code because that's my jam. But I believe the next speaker is actually talking about open data. So it's quite a nice contrast. So there are big things afoot in the world of NHS analytics, as probably most of you know, or some of you know, certainly if you're NHS bods, I'm sure you will. So the GOLDACRE review came out, I think, about 3 months ago. It's a thumping good read. I've read it cover to cover more than once, and I'm not kidding. So there's a couple of very important things in there I want to highlight. It makes big play of what's known as TREs, Trusted Research Environment. So a trusted research environment is a special sort of place, I just realized I didn't set my timer, where analysts can do analytic work safely without downloading pseudonymized / anonymized data to their laptops. It's long been the case in the NHS that most data analysis is done by downloading big chunks of data, and they're even being passed around. The report makes the argument fairly forcefully that that's not very safe and we should stop doing it, and I quite agree. Code-based trusted research environments are superior to the other kind. I don't have time to go into the distinctions, I'm afraid, but read the report. But code-based ones are better, partly because people can reuse the analysis they've done. So they can go, I've used a load of snowbed code. So are you interested in replicating what I've done? And also, I think even more importantly, they facilitate audit. So we can make sure that analysts are using the data safely in the way that they should be using it, because we can log everything that's done. And OpenSafely obviously is held up as being an example of this. That's Ben GOLDACRE's thing. Everything is logged, so it's totally auditable, and that's very difficult with non-code based solutions. Something else in there that's very important to what I'm talking about is something called RAP, reproducible analytical pipelines. Basically, a reproducible analytical pipeline is any kind of analytical process, whether it be a summary or a count or a machine learning model or whatever it is, that requires no kind of human intervention, no clicking, no pointing, no nothing. It runs from start to finish completely automatically. Typically, for example, you might have a SQL, some SQL code that's executed. That SQL code will be passed on to maybe R or Python. That will execute some sort of analytical code, and then a report will be produced automatically, whether it be HTML or PowerPoint or whatever you want. They are big business in government, in the civil service. They are massive on this. They've just published a strategy, which I can also highly recommend. And they've already saved millions and millions of pounds, and they can prove it. And so should we. And that's what it says in the GOLDACRE review. And if you're doing reproducible analytical pipelines, you are coding. There is no other way. That is it. It is code. And that's what I'm going to be saying repeatedly today is if you want to do all this amazing stuff, you have to use code. So that's kind of the point of what I'm talking about, really. And of course, you have to share it, but I'm getting to that. And of course, it says in there, of course it does. It says all NHS procured code for data creation analysis is shared openly. We've all been saying this for years. Finally, it's in black and white. And lo and behold, it's in black and white in the newly published Data Saves Lives policy from the Department of Health and Social Care, written right there in black and white. I shall be taking this to many a meeting for years to come. It says begin to make, but still, new source code that we produce or commission, open and reusable by default. Default being the key word. There are times when you don't need to, you shouldn't or don't need to share your code, but the default is that you do share. And if you don't share, you need to have a damn good reason. Everyone, I'm sure, in this entire meeting has been saying that for years. And they've also talked about publishing a digital playbook on how to open source your code. I think that sounds very helpful. Open sourcing code can be easy, depending on what it is. It can be pretty hard. I think collaborating on code is even harder. That's for another talk. I'm hoping that someone is going to grab that problem by the scruff of the neck, because I've long been saying this, that it's all very well people talking about, oh, let's all collaborate and hang out. And I completely believe in that. But it turns out that actually there are quite a lot of pretty complex technical skills required to do such a thing, which I should be coming back to. Right, so I'm going to be talking about what's called code first data science. This is a phrase in the world, you'll hear this, that's why I've said it, but you could call it analytics or whatever. And it's code first. I would say it's code first and code last in most of the cases. Code is better than alternative methods because it's inspectable, which is something that Alan was just talking about. We have a duty to be transparent and fair. And that's very difficult if you're not using code. Which is reusable, which is clearly efficient. Anything that can be reused is efficient that's very obvious why. It's also extensible, which also means that it's more efficient because it means you can use it more than once somewhere else, but it also means that it's more accurate. So a common problem you see in the world of analytics, it's true in the NHS, I'm sure it's true everywhere, that everyone does something and they all do it slightly differently. This is articulated beautifully in the GOLDACRE review, many things are, and you end up with 12 analyses which all purport to be about the same thing but aren't. And that can be a real problem, and people can end up getting tied up in knots over apparent differences that only exist in the data. And that kind of problem, particularly when it's being considered after the fact, after the analysis is done, is extremely difficult to unpick without a code-based approach. Extremely difficult to the point of really being impossible. And it's reproducible. Reproducible embodies all of those things. Reproducibility is the core value being held up here. So, a quick story. I saw that you're supposed to use stories. I saw someone say that in a thing, and then I saw Rishi Sunak's leadership thing, and he said, "Let me start with a story." And I thought you follow the same people on Twitter that I do. So this is the legendary Linus Torvalds, the creator of Linux. So here he is. This is a message he posted on Usenet some years back, and he says, "I'm doing a free operating system, just a hobby, won't be big and professional like GNU." What a classic line! It's almost like he knew what would happen. It won't be big and professional like GNU. That thing that he built as a hobby now literally runs the internet. It's in your Android mobile phone. It runs the internet. It's been to Mars. It's everywhere. It's really hard to imagine a world without Linux. And if they can't do it, why can't we? Why can't the NHS, which is, I think, is the 5th largest employer in the world, why can't we produce something awesome like that together? I think we can. And again, you can collaborate with non-code-based tools. I'm not going to say you can't, but having code certainly facilitates that. There's no question about that. And there are many tools that the geeks in the audience will be familiar with that facilitate that, doing that. If you're curious, come and find me on the internet. You'll find me shouting somewhere on the internet, so come and ask me. So sharing the analytic code that we're using is really the only way to have truly reusable and truly inspectable analysis. That's what I'm arguing today. I'm trying to make quite a forceful argument today, because you're an easy crowd. I don't want to preach to the choir. If I was in a different thing, I'd probably say something slightly different. All this is going on the internet, which might be problematic in the future. It's really the only way to do this. So I think we need to start doing it. And we have a duty, we have what I consider to be a moral duty to publish what we're doing. And again, this is related to what Ellen was saying about being transparent and being fair and making sure that things are, working in the way that it should be, but also just from in terms of efficiency. The NHS spends a lot of money, on analytics. The government, as I say, the civil service have already saved millions and millions of pounds through that, and they can prove it too, which I think is amazing. Right, so having said all that, we have a massive skills deficit. So this guy on Twitter, this Chris Beeley guy, I think I couldn't put it better myself, whoever he is. Teach a person data science, they can generate insight from the data for a lifetime, but sell their manager a whizzy ML-powered dashboard, and you can charge your organization lots of money for licensing indefinitely. We have a massive skills deficit in the NHS. There are lots of people who want to say, oh, don't worry about that, just buy this, just buy that, just buy the other. And at the end of that, all you've got is a product that you have to keep paying for and a workforce that have learned nothing. So again, I would like to argue very strongly today that we need to stop doing that. Well, the default needs to be to stop doing that. That's the fundamental concept here, isn't it? You will need to do that occasionally, I'm sure. Great, do it. Clearly there'll be times when you're in a rush or whatever it is that you need to do it. But I think it's more important to get people thinking and learning and doing, and that's what we should be investing in, not corporations that don't even pay tax in this country. They're mainly registered in the US. So there are no easy answers. That's the point of that slide. So the time is now, basically. That's what I'm arguing. It's time to wrap everything. That's what it says in the GOLDACRE review. It says it should become, I've forgotten the quote. Let's have a look. What does it say? Let's see it again. Oh yes, the core working practice must be supported by all platforms and teams. Well, that's not true today, and I think it should be, and there's a hell of a long way to go, so let's get started. So we need a lot of training. We need a lot of experiential learning. That's really, really important when people learn this code. People underestimate that. You can't pack someone off a course and go, oh, we've got an R programmer. It doesn't work that way. It's graft and it's time, and you need people to help you. And I should know, because I learned R on my own and it was brutal. You need people to help you. We need mentoring, we need leadership, we need analytical skills in the senior workforce, as we were saying before in the chat. We need to try and get rid of software licensing. It's a drain on resources. It doesn't help, it doesn't solve the long-term problems, is what I'm arguing. So let's get rid of as much as we can. MyTrust did that recently. They didn't really have a program in place to replace the thing that they got rid of, which was maybe not the right way of doing things, but still, it's progress. We're investing now, we're saving money later. And as I've argued throughout this, my overall point for the day is that code first data science, code first analytics is cheaper and better. It's obviously cheaper. A quick Google will satisfy you with that, I'm sure. I hope that I've gone some way, if you weren't already of that opinion, gone somewhere to convincing you today that it is in fact better as well as being cheaper. And I would like to finish with a plug for NHS-R, because it's my favorite thing. It's the best thing I ever was involved in. We do all of those things I've been talking about. What a wonderful coincidence. I've just given a talk and NHS still does exactly that. And of course, the reason why it does exactly that is because it's a community effort. So it does the things that analysts need because it is analysts. And I think that's a key point. People talk a lot about leadership and that's very important. But actually, it turns out if you give people a space and a time to help each other, they do. Who knew? So we do all of that. We do training, we do experiential learning, we build stuff, we build useful stuff. We built stuff for the Making Data Count people over in NHS England who love what we've done. I mean, it wasn't, when I say we, it wasn't me, it was other more talented programmers. We have a library of code, examples of codes and blogs and GitHubs and all sorts of like learning material, raw material. We have a community, which is very important. Ellen beautifully mentioned the word community. And it's all open all the time. That's a big thing in the GOLDACRE review. It says things should be open by default. Data Saves Lives says it should be open by default. And we've been doing it already for years without anyone asking us. So code first is awesome. NHS-R is awesome. That's the pitch.
Chris, brilliant as ever. Thank you for that. The chat's gone berserk. Mainly just
in a good way, I hope.
In a kind of establishing that you're not a Tory, given your Rishi reference.
Totally sold. Good. Well, Slack me, DM me.
Yeah. Yeah. No, really good. Thank you. Yeah. There's various bits and pieces in there which we can kind of come back to. One of the questions I had, and it links to that kind of conversation between kind of us as the analytical community and whatever you want to call them, decision makers, senior leaders, and so on. They do not understand that they can't get their head around yet the difference between a trusted research environment and federated learning, and I think they're conflating a few different things at the moment. I wonder if that might be something that we can look at through one of these, and I can see we've got Catherine Dampney on, which is really helpful. That might be something to consider for one of our future sessions, just to again try and not patronize, but try and give a clear summary and description for people who touch these things, but they don't touch them all day like us. Because I think I get a sense people come to me going, oh, I don't quite get the difference between these, and then trusted research environments are going to change their names as well. So we can come back to that. Okay, thank you. You're bang on time. Thank you for that, Chris. Osman, thank you for joining us. All of this, I think, links to the people at the real coalface, which is in that GP surgery where Alan was kind of probably in the room behind the GP, of what patients and citizens think about this. And you hear sort of broad strokes of people are often annoyed and surprised that we haven't linked up the data from the ambulance service to the hospital to the GP. And all three of them are surprised that the person with diabetes collapsed in the street. It's sort of news to them. But we are doing that in a context of, nervousness about where our data might go, not mentioning any companies, and how it might be used. And I think that's the context for some of what you want to talk about, Osman. But over to you at this point.
Thanks. Yeah, thanks for having me. So certainly that's what I'm going to be focusing a bit on here, and that is very much the concern within primary care. So I'm going to basically give a primary care perspective as a GP and CCIO for North East London, And there is certainly a lot of benefit, but there is also increasing concern. And I think I'm just going to try and balance that discussion really. So if we go right from the beginning and look at what is it that we're actually doing, we're actually collecting patient data for direct care purposes, and that's what the transaction is. So the data we've got is a patient comes into the GP practice and says, I've got this history or whatever. That discussion is recorded, and that remains confidential, and the doctor knows that and the patient knows that, and that is where data is trusted, and trust plays a massive part into what I'm going to be talking about, because I think once trust gets eroded, we lose everything, or we're going to start to lose everything. And I think we are starting that journey to lose things because trust has been eroded for many reasons. So what do we collect the data for? Now, patients, absolutely, they expect whenever they go to hospital, the hospital knows, or the ambulance or wherever they go, that location has the data, and vice versa. When somebody's seen in the hospital, that data comes back to the GP surgery. And you can see that is what we should be working towards, and that's what we would call our level 1 locally, where we've got information at the point of care for direct care purposes, and patients, clinicians all expect that to happen, and that's the primary objective of why we're collecting data and why we're sharing data. Along came the pandemic, and things really got thrown up in the air. We knew that we were previously discussing other ways of sharing data, this analytics, and things happened, but what really changed things was COPI, and COPI has been iteratively 5 times it's been updated, and starting in March 2020 up until the 30th of June it was published on the NHS digital website, and this was clearly outlined, and there was communication that had landed to GP practices. They didn't understand what COPI was, but they knew that this thing happened. And if you looked at the detail as to what it was, I'm not going to read this all out, but there are 7 main points. But I think the main thing is what people came to me and said, actually, at the first line, it says it includes, but is not limited to. So if it's not limited to these things around COVID, what is the real issue here, and what is the data being used for? And we weren't quite sure. And then in the middle of all of those COPI notices, along comes something called GPDPR, which looked to collect GP data for from a single collection, which sounded really great, but it was halted because there was some issues with how the data was going to be used. And with GPDPR, just to outline general concern there, you had NHS Digital taking the confidential information and then giving it out to people without any proper checks and balances. And I think that was a concern that was raised for GPDPR, which is why it was canned, and canned in a way that a letter was written out, quite a detailed letter that came out to actually say, there's some safeguards we want to ensure before we proceed. And some of those safeguards were talking to professional bodies and the National Data Guardian, and making sure that people are aware. People are aware, I think, is the key thing, and people, these are our patients, not just the staff. So that was all paused, and then 1st of July on a separate website, we suddenly noticed, by stealth, I think there were lots of things going on in the last week or two, but the messages that I've got over the last week or two is that this latest COPI notice that has extended the extraction up until October the 31st has been published on a separate website and has not been publicized, and a lot of GPs, including myself, were unaware that this had happened, and we just heard from third parties, and I think this is what is breaking confidence in the system, with clinicians who are collecting the data that's going to be used for planning and research and everything else. And then the other thing that we then did was that we thought, actually, let's go and have a look at what has the data been used so far. So we know that with COPI there are some statistics that you can get out from the collection. Not great, but these were the bits of data that we managed to pull out, and this is up until July, so it is very current. So if you look at the register, and I've linked all of these if you want to look at these later on, there have been over 3,300 requests for data. Some of these are single requests, some of these are multiple ongoing requests, and there's a clear breakdown as to where that data is, and a bit small to read, but generally speaking, the vast majority of requests have come from academic institutions, CCGs, and local authorities by far. So they're your bulk. But actually, if you go down that, there are some other organizations that people probably need to question and say, actually, what does that mean? What's the detail of a ministerial department or commercial, or what does society mean? So it's not that transparent, and again, it raises questions. The other thing we looked at was actually, out of those 3,386 requests, was it all used for planning and research? So what was the COPI notice actually doing? And the data says that actually in 8% of cases, it was used for commercial purposes. And again, if it's being used for commercial purposes, we need detail, and what is going on with the data that we're collecting and somebody else is now using for commercial purposes. And I think, again, it raises questions that we need to balance and have answers to. And if you look at those 3,286 agreements, that there are 26,000 data set requests. So the agreements have been put into place, but there have been quite a lot of requests from those organizations. So 26,000 requests for data. Some are one-off, some are recurrent. And then if we look at the sensitive breakdown, and it's, again, this was quite concerning. So identifiable, so out of those 26,000, a fifth, so just over 5,000 were actually identifiable. So you've got identifiable data being released under COPI, of which 4,000 are classified as sensitive. And again, it raises the question as to, if you want us to be forming some trust, is this building trust if this is how the data is being released and we're not quite sure what you're doing with this data that's identifiable and sensitive? And then if we have a look at a bit more detail, so out of those 26,000 requests, there have been over 46,500 releases of the data because they're ongoing and recurrent. And again, we can drill down. It gets a bit murky the further you go down. So we can certainly see that there is a sizable amount that's identifiable. So we're getting lots of identifiable data that's ongoingly being released. And then we can see actually there is a substantial amount of sensitive data that's ongoingly released. And we can also see that opt-outs, so patients are opting out of data for research and planning. Are these being honoured? And the right thing would be to build trust, is to say, if you opt out, then we will honour that opt-out. It's only been honoured in 8,400 out of 46,000 data releases. So again, is that building trust, is the question I would put out there, if we're giving people the option to opt out and then not honouring the opt-outs. So again, I think it just raises questions, really. I think there's been some concern about how do we move things forward, and I think certainly OPENSAFELY has been put forward as a new way of looking at things from the GOLDACRE review. There are 114 projects on there, and I think that slide is mixed in, but yeah, generally 114 projects that the count for commercial purposes isn't related to the OPENSAFELY, but generally speaking, it's 114 releases from there, and that's based on the GOLDACRE review, really. So the GOLDACRE review has promoted the OPENSAFELY focus, and I think that is a road towards the right, a step along the right road to try to improve things. Although what we really need to try and do is make sure that that is quite transparent, and they do actually say that it is quite transparent and will be. And if you have a look at the approved projects, it does seem to be. And of those 114 projects, I think I can't see any outcomes per se, but what we'd really like to see is what are the outcomes from that. And if we come back to trusted research environments, and I think that's something we really want to be focusing on. And the issue here is OPENSAFELY may well be regarded as a form of a TRE, but the issue is that we're also building, and other people are building, their locally owned TREs. And I think a locally owned TRE will build the biggest amount of trust for not only clinicians and patients to pass data into the TRE, but then a confident way of us actually saying which is the data we're going to be anonymizing, pseudonymizing, or having identifiable, and then allowing other people, NHS Digital or anyone else, to then have the data for any onward purpose. And I think that's what we really need to be focusing on. And on the back of that, they can then think about actually how do we then build some planning and research into the process. And if we go into looking at how do we build trust with patients, it is very much about firming up the opt-out process. It is a mess, is probably the best way to describe it. There are different types of opt-outs, and nobody quite understands it. The simple way of identifying it, there is a type 1 opt-out, which stops data leaving the practice to go somewhere. And then there's a national data opt-out, which prevents it being shared once it has been released. I think they're now out of date, and we need to have a big think about how we renew that, because coming back to the center of it, if we don't have the trust, we don't have the data, we can't do anything with it. Thank you.
Really helpful, Osman, really helpful. Thank you for taking the time to kind of update what you've been through before and do that analysis, because I haven't seen it broken down in that way at all. What's the, from those pie charts and bar charts, what is the row level data? How much information is on it, or is it still a bit murky when you get
that's about as detailed as we can get? There is probably a little bit more information. You probably get the organization that took the data, perhaps, but yeah, I think COPI has highlighted that there probably are agreements, but they're not public and they're not shareable. And can we get hold of them? I don't know. And yeah, I don't think 3,000 odd freedom of information requests is going to be useful for anyone. So it needs to be transparent. And I think the OpenSafely GOLDACRE review is going some way to do that. But we need to build that trust. I think we've lost some of that trust. We have slipped. Can we regain it? Let's see.
Yeah. What's your sense of what will come out through the next sort of 6 months? There's a lot of talk about kind of national comms.
I think the patients need to know what's happening with their data. I struggle, and I think I know what's going on. My colleagues in primary care often don't know what's going on, and therefore, if they don't know, their patients definitely don't know. And like we've been calling when we did the GPDPR discussion and the campaigns, was that we need to have every household, every person, ideally written to, with the same approach that we did for care.data to inform as to what is happening, because I don't think the message is getting out there. And so we are now using patient data that patients are giving with trust for a purpose, and we're using it for a different purpose. And I think patients need to be aware it's not just being used for direct care. And there are people making money and commercializing this data. And if we tell people, I'm sure people will be happy with that, because I think most people would be agreeable. The problem is if it happens by stealth, then it gets people's back up and they'll be like, okay, I want to object to this. And so we get more objections if we're not honest.
Yeah, no, I completely agree. And you contrast it with things like the census, which kind of goes out every 10 years relatively smoothly. We're going to send you some stuff to fill in because we need to know how many swimming pools we need in your town, or do we need a bigger, you just don't get the noise about it, and the comms are just done better. So it'd be really interesting to see what comes out over the next 6 months, 9 months, because there's a lot of, maybe some of these things will be delayed given the events of the last week or so, but the things that we probably all saw a month or two ago said that there's quite a lot going on through the next 6 to 9 months in terms of comms. So we'll see, and I hope this forum is helpful for people in just kind of keeping in contact on that. The chat is busier than I've ever seen. Taz and myself will try and write that up. If you've got time to go in and answer any of that, do. But these feel like issues that we'll kind of come back round to. One thing I mentioned at the beginning, which I'll just mention again for people who might have been a couple of minutes late. Thanks very much for coming to these. We've changed the frequency of them, but to try and make them slightly more formal, slightly less chaotic. And this one has been, we did cancer before, which a lot of work has come out of, and we want to do inequalities probably as we sort of come back after summer. For me and a number of people I speak to, it's become almost the number one issue in a really positive way. We're starting to do a lot of analysis of data by all sorts of demographics, and it has to be done really carefully. So I'm very, very keen to get people together who have a particular interest in that. So if that rings a bell with you as an individual, or you've got a friend Bob who's very interested in that as well, please keep in touch. Usual methods of communication, everything is available. To Chris's point, there's no sort of silly passwords to get beyond NHS Futures. This is all just on the internet. Contact us through the website, through Twitter. We'll write this up, and we're starting to publish a lot more stuff through GitHub as well. As a lot more regions are just going, well, here's all of our warehouse code. So we're doing that in Kent, for example. Kind of keep collaborating, and thanks ever so much for everyone joining. I wanted to always try and finish a few minutes early just to give you space before your inevitable 1 o'clock meeting. So thanks everyone for dialing in, and I'll see you in person tomorrow, hopefully. And see you all soon. Take care, everyone. Cheers. Bye-bye.